Hi, my name is Jessica Shoemaker, and I will be performing a respiratory exam today on my patient, Shoemaker. The first thing I would do prior to walking into the room would be to gather all my supplies, which is my stethoscope, a ruler, and a pen, perform hand hygiene, get any PPE that I would need, and set up the exam table or the chair, the space for the patient to make them feel comfortable. So coming into the room, I'm going to assess my patient's general appearance. I'm going to gather vital signs as well. So the general appearance, I'm going to be assessing their breathing rate, rhythm, looking at them to see is there any accessory muscle usage, any difficulty breathing, is there any audible breathing sounds, wheezes or like stridor, is there any tracheal deviation, looking in that sternal notch, making sure the trachea is midline and not off to one side. Also looking for any cyanosis anywhere, any clubbing of the fingers, any discoloration, and symmetric lung movement. So these are all things I can do with my general appearance just by looking at my patient. I can get a lot of data. And then I'm also going to inspect them and look to make sure, is the chest AP lateral diameter, how are they different from each other? Is the patient barrel chested, or is the chest concave excavatum, or is it more of a pigeon chest? Those can tell me a lot of things as well. So check the barrel chest, you'd see more in your restrictive lung diseases. So then after looking at all of that, I want to assess symmetric lung expansion. So I'm going to place my hands at the costal margin. I'm going to get the patient to take a nice deep breath in and out. And so my hand should move symmetrically, and about 2 centimeters is normal. I'll get you to turn around for me. So on the posterior chest, I'll do the same thing, except I'll go to the costal vertebral angle, and I'll place my fingers there and get them to take a deep breath in and out. And then restrictive lung disease, you wouldn't see that movement. And it's important that it's a symmetrical movement. So the next thing I'm going to do is I'm going to palpate the chest. So I'll start on the posterior side since my patient is turned this way, and I'm just going to palpate the entire chest. I'm looking for any tenderness, bruises, any suspicion of rib fracture, any deformities. Do I feel any subcutaneous emphysema or crepitus? Great, and I'll get you to turn around. So checking the apices, not forgetting the apices. So again, feeling for any crepitus, subcutaneous emphysema, any tenderness, deformities, or suspicion of rib fractures. Okay, so after that initial palpation, we need to palpate for tactile firmitis. And tactile firmitis, I'm going to use the ulnar side of my hands, and I'm going to get the patient to say 99 every time I place my hands on his chest.
99, 99, 99, 99, 99.
Perfect. You just turn around.
Ninety-nine, 99, 99, 99, 99, 99.
Perfect. Okay, so now since I have him facing this way, after we palpate, we need to percuss. So we're going to go in a ladder pattern, and we're going to be starting with the apices. So that lung should be really nice and resonant sounding. Making sure I'm in between the lung, in the interspaces. Not over any bone. The scapula, you hear dullness, so trying to stay away from that. making sure that you don't forget that right middle lobe. Okay, so everything sounds nice and resonant. If you hear any dullness or hyperrenaissance, would be any air trapping in the lungs. So I'll get you to turn around. Perfect. So we're going to do those apices again. So it's nice and resonant. Again, you might hear some dullness over the heart. And a female patient, I would have to displace the breast a little bit to be able to properly do this. And again, we're here. Not forgetting that right middle lobe. So it's nice and resonant, no dullness. So now I'll get him to turn around. While he's on the back here, we'll be checking for diaphragmatic excursion. So how I do that, this is what I need my pen and my ruler. So I'm gonna get him to take a deep breath in and exhale forcefully, so get all that air out. And now I'm going to get you to take a deep breath in and hold it. So I'm going to measure. And he is about 5 centimeters right there. So his diaphragmatic excursion is 5 centimeters, which is normal. It's 3 to 5 centimeters. So for the purpose of this, I'm not going to be repeating the other side, but you would be doing both sides and comparing them and see if they're symmetric. The left side might be a little bit less just due to the heart. Okay, so after the diaphragmatic excursion, now I'm going to auscultate. So I'm going to auscultate with the diaphragm of my stethoscope and listen to a ladder pattern. I'll be hearing vesicular sounds, sort of much more low-pitched over most of the lung fields. Bronchiovesicular in the first and second interspaces, bronchial close to the manubrium, and then tracheal sounds are over the trachea. So I'm just going to get you to take a deep breath in and out. So listening for a full breath cycle, inspiration and expiration at every landmark. Fantastic, and I'll get you to turn around. Not forgetting the apices of the lungs. And up in that right lung. Great. So now I'm going to be doing, so listening, again, making sure there's no crackles or wheezes, adventitious sounds, nice and clear. Airway entries, nice and equal and clear. So again, tracheal sounds would be here over the trachea. We'd have vesicular sounds, bronchiovesicular in the first and second interspaces, and then you'd also hear bronchial sounds over the manubrium. So we're going to do a voice transmission test. The patient's going to say 99 every time. Okay.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Perfect, and we're good to turn around. So any increase in the sound could indicate consolidation or mass, so I'm checking for that.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Perfect. So it's nice and consistent throughout. Thank you so much for listening.